Good morning, everyone. Honorable Omkar sir, esteemed seniors, my dear colleagues and students. Before proceeding on to the case, I'll give a brief introduction of our department. This is our small department. We have total 8 units with we have total 8 units with 11 professors and 3 emeritus professors. Total number of beds are 240. More than 200 OPD patients we attend on daily basis. 50 to 55 new admissions in a day. ICU occupancy is almost 100%, and with a reasonably good occupancy in the wards as well. Publications, over 80 publications have been contributed by our department faculty and residents over the last 5 years in indexed and national and international journals with high impact factor. Recent publications from our department in 4 renowned international journals were in the Journal of Research in Clinical Medicine, International Journal of Infectious Diseases, Journal of Royal College of Physicians of Edinburgh, and International Journal of Scientific Research. Numerous chapters in medicine textbooks year after year, and 5 out of 100 case reports in the book of 100 interesting clinical cases have been contributed by our faculty and residents. Overall, around 25 chapters in textbooks in last 5 years have been published yet. Our faculty and residents have authored 5 chapters in yearly publication of Medicine Update this year 2024. Various faculties from our department have received fellowships and awards on the international and national platform. Fellowship of International Medical Sciences Academy. 4 of our faculty received the prestigious FIMSA at IMSACon Jaipur on December 2023. Fellowship of Diabetes India. 2 of our faculty members were awarded with this fellowship at Indore in April 2023. 3 of our faculty members were conferred with the prestigious Fellowship of Indian College of Physicians at Epicon 2023 at Ahmedabad. This year, Dr. Kishore Mulrajani will be awarded with FICP at Epicon 2024, New Delhi. Dr. Anjan Kalia is the 4th one to receive this prestigious Fellowship of Royal College of Physicians, Edinburgh this year. Organized IPF MidCon 2022 in August and Raj Epicon 2022 in November at our institute, and was a huge success, largely attended by over 800 delegates from all over the country. Our faculty has been a part of various national and international conferences as speakers and panelists. The 40th annual conference of the International Medical Sciences Academy was held at Mahatma Gandhi University on 2nd and 3rd December 2023. The upcoming conference, an international conference with UK and South Asian countries, IPF Medicon 2024, will be organized at our university on 6th and 7th of April, and the speakers from Sri Lanka, Nepal, Bangladesh and the United Kingdom will be attending this conference. Value-added courses. Department of Medicine has organized various value-added courses for students and faculty like BLS and ACLS. Dr. Mukesh Sharma and Dr. Anjan Kalia are AHA certified instructors for these courses. Our department regularly conducts seminars on good clinical practices in the form of case discussions, journal club and topic presentations. PG students have proved to be a great asset to the institution by securing top positions in paper presentation, poster presentation, quiz at state and national levels. Bit about alumni progression. Alumni of our department are successfully working as faculty and senior consultants in various public and private sector hospitals and medical colleges. Around 40% of our alumni have either completed or are pursuing DM in reputed institutes like NIMHANS, Adheesh Cancer Institute, Chennai, and working as super specialists throughout the country. Many have opted for fellowship programs, and an alumni meet was also organized last year. This is the list of our students who are either pursuing or have completed their super specialization. Cultural activities. Apart from academics, our department also has a lively cultural environment, and we recently had the privilege of winning second position in the stage performance during the first Foundation Day of the Advanced Center for Medical Genetics. We also have representation in various national and regional bodies of the physicians like National API Association of Physicians of India, State API, ISCM, IPF, American College of Physicians, and many more. Now, last but not the least, the Department of General Medicine is proud to announce that we are publishing a textbook of clinical examination in medicine in English, which will be ready for publication by the end of this month and will be launched in February 2024. This is the brainchild of our Sir Dr. G.N. Saxena sir, who has worked very hard along with our faculty and residents over a period of 1 year. So now coming on to the case, I invite Dr. Chinmay.
Thank you, sir. Good morning to all respected teachers, seniors and colleagues. Today we will be discussing case of 33-year-old male with unexplained fever and weight loss. Our patient, a 33-year-old Hindu married male, resident of Shiopur, Madhya Pradesh and shopkeeper by occupation, he presented to Mahatma Gandhi OPD with chief complaints of fever for 6 months, weight loss and decreased appetite for 6 months, loose stool for 4 months, cough with expectoration for 2 months and oral ulcer for 15 days. Coming to history of presenting illness, he had fever which was low grade, intermittent type with no diurnal variation, without any chills or rigor, relieved after taking medication associated with decrease in appetite. Initially, he used to have 5 chapatis and on presenting he was having 2 chapatis a day. With significant weight loss of patient being of 65 kgs initially and was of 50 kgs on presenting over a period of 6 months. Loose stools 3 to 4 episodes per day, semi-solid in consistency, yellow in color, non-foul smelling, not associated with any complaint of pain abdomen, without any blood or mucus associated with stools. A patient also had complaint of multiple oral ulcer over mucosa of tongue, soft and hard palate. Patient had complaint of cough with expectoration which was gradually progressive. The expectorant was white in color, copious in amount, approximately 8 to 10 teaspoons a day, thick mucoid in consistency, non-foul smelling, and also there was no diurnal or seasonal variation, postural variation, aggravating or relieving factor, no complaint of orthopnea or paroxysmal nocturnal dyspnea, and no complaint of blood-tinged sputum. Patient had negative history of pain in abdomen, palpitation and excessive sweating, genital ulcers, night sweats, burning micturition, chest pain, alopecia, joint pain, no history of travel outside the city, no history of blood transfusion, no history of drug allergies, and no history of exposure to pet or birds. Coming to past history, our patient had no history of diabetes mellitus, tuberculosis, bronchial asthma, hypertension, or medication for any chronic illness. But he was multiple times admitted outside for fever, for which he was given symptomatic treatment, and post which he was discharged, but no definitive diagnosis was made. He has no significant family history. Coming to personal history, he was non-smoker, non-alcoholic, vegetarian by diet, bladder habits were normal, sleep was normal, appetite was reduced, increased frequency of motion with semi-solid consistency and no high-risk behavior. Now to summarize our case, we have a 33-year-old male who presented with intermittent low-grade fever for 6 months, significant loss of weight 15 kgs in approximately 6 months, loose stool for 4 months, copious cough with white expectorant for 2 months and oral ulcer over tongue and palate for 15 days without any comorbidities. Now can I ask our audience what differentials can they think of? So we have classified a differential diagnosis.
IBD as the first diagnosis. How do you explain the cough? How do you explain? So whenever you have symptoms related to multiple systems, you should think either of a systemic disease or a disease which involves multiple systems. So what would you like to change? Which infection? Yeah, a long history, fairly long history, multiple systems involved, GI and pulmonary symptoms. I think the first clinical diagnosis based on this history should be tuberculosis. I don't know whether any other systemic... HIV.
We have classified a differential diagnosis on the basis of complaints like fever with weight loss associated with productive cough or oral ulcer or rash or loose stools. So these are various differentials that we have jotted down. Infective being tuberculosis, cryptococcosis, histoplasmosis, malignancy, ILD. Causes of fever with weight loss and oral ulcers being infections, Behçet's and malignancy. Causes of fever, weight loss and oral rash being infectious causes like tuberculosis, leprosy, autoimmune like sarcoidosis, SLE, lymphomas and leukemias. Causes of fever with weight loss and loose stools being secretory, inflammatory, GI or dysmotility. Now we have classified and jotted down to narrow it under various headings. Infective causes being viral like HIV, bacterial causes being tuberculosis and brucellosis, fungal causes like cryptococcosis, histoplasmosis, coccidioidomycosis, parasitic causes like Vaucheria, Leishmania, malaria, GI causes being IBD, autoimmune causes or malignancy, and thyroid disorders. Our patient was vitally stable except he was febrile and temperature was 100.2 degree Fahrenheit. On general physical examination, he was poorly nourished with loss of buccal pad of fat, supraclavicular hollowing and cachexia. He had oral ulcer over the mucosa of palate and tongue. Surrounding mucosa is erythematous and skin rash were present, papular rash with central punctum. We'll describe oral ulcers and skin rash in detail in upcoming slides. Patient had pella present on general physical examination. Rest, icterus, clubbing, cyanosis, lymph node, edema and JVP were normal. On systemic examination, he had spleen palpable 2 cm below costal margin, soft in consistency, non-tender and splenic notch was not felt. Rest other systems were normal. On day 1 of investigation, he had pancytopenia. Hemoglobin was 6.7 gram per dl, WBC being 2400 and platelet count of 40,000. PBF was normocytic normochromic with RBCs showing anisopoikilocytosis in the form of teardrop cells and occasional elliptocytes. And ESR was raised to 90. RFT, LFT were normal. On electrolyte examination, he had hyponatremia, sodium being 128 millimole per liter. Chest X-ray showed prominent bronchovascular markings and few calcifications on the right side. And USG whole abdomen was suggestive of mild splenomegaly with 14 cm in largest dimension. We'll again summarize our case of a 33-year-old male with intermittent low-grade fever for 6 months, weight loss significant 15 kgs, loose stool for 4 months, cough with copious white expectorant for 2 months, oral ulcers over tongue and palate for 15 days. On examination, he had pellar present and palpable splenomegaly. Lab report suggestive of pancytopenia, raised ESR, PBF being normocytic normochromic with anisopoikilocytosis in the form of teardrop cells and occasional elliptocytes. So we have added differential.
एक सेकंड, बड़ी अच्छी इम्पोर्टेंट बात बताइए. जो कबूतरों को दाना डालते हैं ना, कबूतरों की जो बीट होती है, that causes this cysticercosis, which leads to the interstitial lung disease. This I was told about 55 years back. So please avoid the habit of giving the danas to okay?
Now we have added some more differentials. Infectious causes being viral causes like HIV, bacterial causes being tuberculosis, fungal and parasitic, and also hematological disorders. So because our patient had pancytopenia, we have added 2 types of cellular bone marrow involvement being hypocellular or cellular marrow. Hypocellular marrow can be myelodysplastic syndrome, aleukemic leukemias or lymphomas, and cellular marrow being myelofibrosis or infectious infestations of bone marrow by various bacteria, viruses and parasites. We have added malabsorption syndromes, GI tract disorders like IBD, thyroid malignancy and autoimmune being the one we have already discussed. We have planned further investigations to rule out our differentials like vitamin B12, iron profile, stool for occult blood, ova and cyst, thyroid profile, antinuclear antibody by IFA, HIV 1 and 2, blood culture and sensitivity, CT thorax, sputum for culture sensitivity, acid-fast bacilli, gram stain and QH mount. Now I would like to call Dr. Amrit from Department of Dermatology to discuss about skin rashes.
Thank you, Dr. Chinmay. Good morning, respected teachers, seniors, and my dear colleagues. So the patient was referred from Department of General Medicine in view of the skin lesions over body since 2 months. On examination, there were multiple, well-defined, discrete, skin-colored papules with central umbilication present over face, upper chest and upper back. There were also multiple, well-defined skin-colored papules with central brown crust present over the chest and bilateral upper limbs. On oral mucosa examination, there were multiple, well-defined superficial erythematous erosive lesions of size less than 1 cm noted over the tongue and hard palate. Other mucosae, hair, palm and soles and nails were all spared. Now I would like to ask the audience if they can think of any differential diagnosis of umbilicated lesions over the body. Yes. Yes. So the differential diagnosis of umbilicated lesions can broadly be divided into infective and non-infective causes. The infective causes include viral infections like molluscum contagiosum, varicella, eczema herpeticum, fungal infections like cryptococcosis, histoplasmosis, penicilliosis. Non-infective causes include non-infective granulomatous conditions like granuloma annulare, sarcoidosis, perforating disorders like reactive perforating collagenoses, perforating folliculitis and perforating lichen nitidus. Soft tissue tumors can also be included in the non-infective causes, and these include sebaceous gland hyperplasia. Now the lesion started 2 months back from the center of the chest and progressed to involve the entire upper chest, face and proximal half of bilateral upper limbs. They were not associated with pain or itching. A bedside zinc smear was made, which was negative, and HIV 1 and 2 antibody reports were traced, but they had not yet come. Coming back to our differential diagnosis, so the first one being molluscum contagiosum. As the lesions of molluscum contagiosum are dome-shaped papules, they're having a pearly, waxy white appearance, and the zinc smear for the same was negative, so it was ruled out. Varicella and eczema herpeticum are generally acute conditions, and the duration of this disease was 2 months. Also in varicella, the distribution is cephalocaudal and it has an erythematous base. Eczema herpeticum is a disseminated herpes simplex virus. It also has a monomorphic appearance, and the lesions appear in crops with an erythematous base, so it was ruled out. Coming to a non-infective granulomatous conditions, granuloma annulare is not associated with any symptoms. It's generally asymptomatic and not associated with fever or weight loss, and generally has an annular appearance, so it was ruled out. For sarcoidosis, the patient did not have any lymphadenopathy, and on chest X-ray, no hilar lymphadenopathy was found, so it made the differential less likely. Perforating disorders are generally associated with chronic renal disease or diabetes mellitus, which was absent in this case, so it was ruled out. And soft tissue tumors like sebaceous gland hyperplasia are generally found only over the face, and here they were present over the chest and bilateral upper limb, so it was also ruled out. So our final differentials kept were first histoplasmosis because of the fever, weight loss and oral ulceration, penicilliosis and cryptococcosis. A skin biopsy was sent for routine histopathological examination along with periodic acid shift staining and India ink staining. So now I would like to call Dr. Kashish from Department of ENT to further continue this discussion. Thank you.
Thank you, Dr. Amrit. Good morning, everyone. Respected faculty members, seniors and colleagues. The patient was referred to us from the Department of General Medicine with the complaint of odynophagia since the past 15 days. It was associated with both solid as well as liquid diet. It was insidious in onset, progressive in nature, and aggravated on eating spicy food. There was no history of smoking or tobacco chewing. There was no history of previous oral ulcers or immunocompromised status. There was no history of any trauma or any significant drug intake. The oral cavity examination was done after taking due consents. It revealed angular cheilitis. Angular cheilitis was seen. Erosive lesions were seen. They were multiple and of size around less than 1 centimeter in the oral cavity, involving the base of tongue, the soft palate, the tonsillar pillars. They bled on touch. The surrounding mucosa was inflamed, edematous and congested. The posterior pharyngeal wall was congested. On 70-degree rigid fiber optic telelaryngoscopic examination, We saw a congested and edematous endolarynx, including bilateral arytenoids and AE folds. Arytenoids and AE folds were edematous, vocal cords were bilaterally mobile, erosive lesions were seen. Other structures such as the epiglottis, pyriform fossa, etc. were edematous but otherwise normal. Based on the history and clinical presentation of the patient, we considered the following differential diagnoses. They were grouped into infectious and non-infectious causes. The infectious causes include viral causes such as herpangina, herpes simplex, hand, foot and mouth disease, bacterial causes like Vincent infection, tuberculosis, syphilis, fungal causes like candidiasis, coccidioides immitis, Cryptococcus neoformans, blastomyces dermatitis, histoplasmosis. Non-infectious causes include nutritional deficiencies, pre-malignant lesions such as leukoplakia, erythroplakia and oral submucous fibrosis, malignancy, and other causes like autoimmune diseases, drug-induced causes, trauma and GERD. We treated these oral lesions with multivitamins like capsule vitamin B complex, tablet folic acid, proton pump inhibitors and prokinetics, syrup antacid and ointment Kenacort local application. Now I would like to invite Dr. Mahima Aneja from the Department of General Medicine to take the discussion further.
So taking the discussion further, on further investigating the patient, the day 2 and the day 4 CBC of the patient revealed persistent pancytopenia with a worsening of the platelet count in a decreasing trend. The electrolytes that were earlier showing hyponatremia had also worsened and the serum creatinine had also risen. That could be leading to the progression of the primary disease or due to the AKI, pre-renal AKI that had developed due to the diarrhea. The anemia workup had showed a reduced corrected reticular count and the total iron workup. ANA by IFA was negative, thyroid profile was within the normal limits, stool for ova cyst and occult blood was negative. Sputum examination revealed gram-positive cocci in the gram stain, rest others were negative. Viral markers turned out to be negative for the patient. On the day 6th of the admission, patient had an episode of bleeding per rectum, which was described as fresh blood, not mixed with stools, no pain in abdomen and no tenesmus. Routine investigations were sent for the day and surgery reference was taken, which revealed a normal PR examination. The CBC for the day revealed severe pancytopenia with a severe thrombocytopenia of 5000 and normal PTINR profile. Injection tranexamic acid 1 gram was given to the patient along with a supportive treatment in the form of blood products was given. Patient was advised for colonoscopy, for which the patient denied, and there was no other episode of bleeding. The subsequent CBCs after the transfusion still revealed pancytopenia with platelet counts of 34,000 and 52,000. So what could be the differentials that could be thought after this, the labs and the history of the patient? Anybody from the audience would like to answer? So surgery exam...
It's only PR. PR does, that is specifically mentioned, because if a patient is having fresh bleeding per rectum, the commonest cause in population would be hemorrhoids. And we must remember that hemorrhoids are not palpable. You do a PR may be normal. They are only seen. Unless they are complicated, they will not be palpable. So every patient who has bleeding per rectum must have, whether the patient is admitted in medicine, Hematology, ENT, anywhere, must have a rectal examination and a proctoscopic examination.
So working on the differentials and ruling out those on the basis of the laboratory investigations, the differentials that were kept under 2 umbrellas, that was the infective, which was the fungal, and the hematopoietic disorders, as the pancytopenia could not be explained. So as to explain the pancytopenia, we had sent a bone marrow aspiration and biopsy for the patient. Now I would like to call upon Dr. Omkar from the Department of Hematology for the approach to a patient with pancytopenia.
Thank you, Dr. Mahima. Good morning, respected teachers, seniors and colleagues. I'm Dr. Omkar from Department of Clinical Hematology. I'll be taking this discussion further. The hematology reference was done in view of pancytopenia. The CBC of this patient showed hemoglobin of 5.7 gram per deciliter. TLC was 3100, platelets were 21,000. Other parameters were normal. The peripheral blood film showed normocytic normochromic RBCs with anisopoikilocytosis with few teardrop cells. Where there were no blast, no left shift or no NRBCs and platelets were reduced. The reticulocyte count was 3.5% and with the correct reticulocyte count of 1.42% and LDH was 192.5. Other investigations including PT, NRPTT, fibrinogen, urea creatinine and bilirubin were normal. So, coming to the causes of fever with pancytopenia with splenomegaly, we divide into three causes: infective, non-infective and malignant causes. So, going for the infective causes, the first differentials which came to our mind was retroviral diseases in view of the patients presenting complaints, but the serology was negative. The second DD which we thought of was tuberculosis again, but the sputum and the tissue culture was negative. There was as such no focus so far found. The third DD was leishmaniasis, but the patient was not living in the endemic zone or traveled to the zone, so it was again a very less possibility. The fourth DD. Pardon, sir?
Which zone, which country?
Sir, in the Bihar and some part of the UP, sir, generally patients with leishmaniasis to come. So the fourth DD was histoplasmosis in view of long-standing fever and chronic multisystem disease. But the clinical manifestation of histoplasmosis usually happens in the immunocompromised, and it's very less likely to be present in immunocompetent patients. In non-infective causes, the first differentials which sort of was sarcoidosis in view of fever pancytopenia, but there was no X-ray changes. Patient had no dyspnea, there was no ocular involvement. The second DD was SLE, but the NA was negative, there was no joint pain. The hemophagocytic syndrome was the third DD which we thought of, but the triglycerides were normal, fibrinogen were normal, the ferritin was normal, so it was ruled out. So coming to the malignant causes, leukemias in view of fever, pancytopenia, splenomegaly, but patient had a long history of 6 months. There is no blast in the peripheral blood film, the differentials were normal, so it was ruled out. The second DD was myelodysplastic syndrome, but again no blast in the peripheral blood film, differentials were normal. The third DD was primary myelofibrosis, but it is mostly of elderly disease. There was no massive splenomegaly which we expect, and no NRBCs, there was no left shift. The fourth DD was hairy cell leukemia in view of long history of fever and splenomegaly, but there was no hairy cells in the peripheral blood film, and differentials were again normal. So the blood bone marrow aspiration biopsy was sent, and the report was awaited. So I would like to call Dr. Shikha from Department of Oncopathology to take this discussion further. Thank you.
Thank you, Dr. Omkar. Good morning, teachers and colleagues. Now I will be discussing the pathological aspect of the specimens we received in our department. First of all, we received the skin biopsy, which shows the numerous positive fungal organisms in the dermis. Secondly, we received the bone marrow aspiration and biopsy. The bone marrow aspirates were hypocellular, the only cellularity which was found in the imprint isthmus. So this first diagram represents the imprint isthmus. So here as we can see that there are numerous intracellular and extracellular organisms in our Leishman stain section. So the bone marrow biopsy of this specimen of this patient shows the uniform granulomas. Here as we can see that these are the epithelioid cells, collection of epithelioid cells, and numerous organisms. Here as we can see that both intra and extra cytoplasmic. So to confirm it further, we did the PAS stain, and these organisms were PAS positive, and GLS Gomery's methanomen stain was also done to find out whether these are fungal filaments or not. So here as we can see that these are the Gomery's methanomen stain positive organisms. So to conclude, small uniform oval yeast are seen within the histiocytes both inside and outside. Uniform granulomatous reaction seen, and the periodic acid shifts and Gomery's methanomen stain positive organisms are seen. So the final diagnosis of bone marrow and skin infiltration by histoplasmosis is given. Thank you. Now I would like to call Dr. Mahima to continue the case.
So the final diagnosis that was kept for the patient, for a 33-year-old male presenting with prolonged fever, weight loss, poorly nourished, having pallor, with pancytopenia raised ESR, and a skin biopsy and bone marrow, both showing infiltration by histoplasmosis. The diagnosis that was kept was progressive disseminated histoplasmosis involving bone marrow, skin, GI tract, respiratory system, and the kidneys. So for the management of the patient, injection conventional amphotericin B 1 mg per kg per day
IV infusion of 500 ml dextrose was given slowly over 3 to 4 hours for 2 weeks. Serum electrolytes, LFT and serum creatinine were monitored daily. Supportive treatment was continued for the patient along with the pre-medications, and after 2 weeks the patient was shifted on tablet itraconazole 200 mg twice a day and is being still continued for the patient. What can be the causes that led to histoplasmosis infection in this patient? Some of the common causes can be HIV, malignancy, drug abuse, addictions, any comorbidities, transplant patients or the genetic disorders. Most of these were being ruled out on the basis of the history and the laboratory investigations. The genetic disorders that can cause an immunocompromised state are enlisted below. Some of the immunodeficit conditions that can lead to such fungal infections include the cellular and the combined immunodeficit conditions, the phagocytic and the other conditions. The CD4 count that was being sent for the patient was normal, which revealed that the patient was immunocompetent. This was the condition of the patient when the patient was being discharged from our hospital. The current status of the patient is that he has an improved appetite, weight gain of 5 kg, there's no fever spike, there's no cough, there's no diarrhea, and the skin lesions are reducing. The current CBC of the patient revealed a normal picture with normal RFT and the LFTs, and this is the current picture of the patient. This is a video message from the patient.
कोटा, बारा, सोपुर, सवाई माधोपुर, पर मेरा कोई इलाज नहीं हुआ। कम से कम मैं 8 महीने से बीमार था। फिर कोई आदमी ने मेरे से बोला कि तुम जयपुर जाओ। मैं जयपुर गया महात्मा गांधी हॉस्पिटल में, तो वहाँ जाते डॉक्टरों ने मेरे चेक किया और बढ़िया इलाज किया उन्होंने, तो मेरे आराम मिला बढ़िया। आज मैं बढ़िया हूँ और बढ़िया इलाज किया उन लोगों ने, और हॉस्पिटल भी बढ़िया है। महात्मा गांधी सबसे बढ़िया हॉस्पिटल है। और बबलू राठौड़
I would like to call upon Dr. Adheesh.
This was the echoed by American Medical Association also, one of the best hospitals they have visited in the country.
मैं जयपुर में जगह घूमा।
Now I would like to call upon Dr. Adheesh for the review of literature.
Thank you, Dr. Mahima. Good morning to respected dignitaries, professors and my dear colleagues. So, histoplasmosis, essentially a fungal infection caused by Histoplasma capsulatum, would commonly manifest in its disseminated form in the immunocompromised or the ones on immunosuppression therapy. So, is disseminated histoplasmosis an important differential to consider even in an immunocompetent person? Our case and the literature says yes. A study published in the American Journal of Tropical Medicine 2017 from Chennai gave an account of 144 cases between 1994 to 2017. They note, with respect to immunocompetent status and disseminated histoplasmosis, they noted a clustering of cases in the Gangetic Delta in the northeastern and eastern provinces, where commonly they would come with oral ulcers, skin manifestations, dissemination to liver, spleen, and gastrointestinal involvement was found to be in 70 to 90% cases. Here, we can take note of the year-wise distribution of cases from the various states, with West Bengal, Assam, and Uttar Pradesh leading the stats. Another study published in the Mycopathology in 2017 by AIIMS New Delhi gave an account of 214 cases, 10 from their very own institute, between 2001 to 15. With regards to immunocompetent status and disseminated histoplasmosis, they found a predisposition in the middle age group, commonly from the rural settlements involved in agricultural activities, and male preponderance was noted, 6:1 ratio, with the probable protective mechanism of beta estradiol in the women against histoplasmosis. Prolonged fever, again, was a common manifestation. Another study published in the Mediterranean Journal of Hematology and Infectious Diseases in 2016 from Calcutta gave a single-center retrospective analysis of cases between the 2009 to 14. 5 out of whom were males immunocompetent with disseminated histoplasmosis. 71% came with prolonged fever. 14% had mucocutaneous ulcers. Here they also mentioned about the better efficacy and the better tolerance of liposomal amphotericin B. So what we see is disseminated histoplasmosis, even in an immunocompetent individual, can be an important differential to consider in case they come with prolonged fever, weight loss, oral ulcers, skin manifestations. In case you find them with hepatomegaly or splenomegaly on examination, you find their X-ray to have hilar, mediastinal lymphadenopathy, infiltrates also. It is an important differential to consider, especially if the person is coming to you middle-aged, from rural settlements, in agricultural activities, or exposure to birds. So if I could leave you with this: thorough evaluation comprising detailed clinical history, meticulous examination is of paramount importance in every patient. Multidisciplinary approach towards the patient benefit not only the patient but help the early diagnosis. Unambiguous approach toward investigation, more guided by clinical thought, is more appropriate and cost effective, as in our case we could promptly diagnose disseminated histoplasmosis and begin treatment early on with the help of skin and bone marrow biopsy. Furthermore, we could relieve our patient of an illness he had been suffering helplessly for months on end. This patient was very poor, coming from a different state, having suffered for many months without any answers. He came to us, and we'd like to thank Emeritus Chairperson Sir, the entire management of our prestigious institute, for giving this patient an opportunity of not only receiving treatment, but Dr. R.C. Gupta Sir, you too, for the many concessions and the many support to give this person a quality treatment. We also thank the CCR Review Committee for helping us, guiding us throughout our journey to bring this to you today. We thank the dignitaries present here. We thank the various departments that helped us, guided us, and enabled us in reaching an early effective diagnosis, starting a treatment very promptly. Thank you, Dept of Oncopathology, Hematology, ENT, Dermatology, and we also like to thank our unsung heroes, the inexpendable staff. And we'd like to thank the patient and his family for trusting us, trusting this institute. Thank you, one and all present here, and good day.